What does healthcare really contribute to our lives? That's a simple question, but it's not so easy to answer. But in the past decades, it seems that something has changed. And many policymakers are actually raising this question. And we can call it value-based healthcare and people-centered health systems, responsive health systems. But today, I won't bother you too much with definition questions. And we go straight to the point. Health systems need to change. My primary care friends, I work for the Organization of Economic Cooperation and Development. It's an organization with 37 member states. And we have a slogan, which is better policies for better lives. So everything we do at OECD is because we want to make lives better. And we believe that good policies is a way to reach that. And you might be professionally involved in healthcare as a policymaker, as a healthcare manager, as a provider, etc. At conferences like this, we often talk about so-called stakeholders. But chances are that you have also been a patient once or more in your life. Because patients are basically people, and most people are patients once in their life or more. And the last time you used healthcare was not because you liked it. It was not because you wanted to use healthcare. It was because something was affecting your daily life and you hoped that healthcare could make that better. And we often talk about patients, but being a patient is just one of the many roles people play in life. Apart from being a patient, they are parents, they are employees, they are friends, they are partners. And fulfilling all these roles can sometimes be hampered by, for instance, pain, by problems with mobility, the loss of functions, sleep deprivation, etc. So I hope we can agree that the real purpose of healthcare is helping people living better lives. Now, the OECD is also an economic organization, and we are interested on returns on investment in health systems. And the investments are relatively easy to measure. Across the OECD, our member states spend almost 10% of their GDP in health. And this brings me back to what I want to talk with you about today. The results. So what do we get back? What do health systems deliver back? To what extent do they make the lives better of the people using them? Does this major investment, 10%, really pays off? Now, I'm challenging you to take a closer look, and I'm going to move myself a little bit here. Here are just a couple of quite random facts that we based on our OECD data that we have. And some of you might know we have, together with WHO, I think we have basically the biggest database in the world with healthcare related statistics. And just a couple of facts. You see, up to 20% of health spending in the OECD is ineffective and probably wasteful. There was an analysis that we did in 2016, which is called Tackling Waste. There's also a 5-fold variation across countries in the number of hospital admissions for diabetes. That is not just because of differences in prevalence. It is because of differences in the quality and access of ambulatory care. This is a so-called ambulatory care sensitive condition. So there's a lot of variation there. We did some studies about opioids, and also there we see a 5 times higher use in some countries than in others. So if we take a closer look to health systems today, to what extent do they really deliver what we expect? To what extent do they contribute to those things that make life worth living? Health systems generate tons of data. Well, just look at our website in the OECD database. There are international data on spending or morbidity, mortality, prescriptions, number of doctors, number of beds, all important, definitely important, but there's almost no data on the outcomes of care, of how care affects people's lives, and also on the experiences of care. So how do patients experience the healthcare that they receive? Well, also most of the health ministers in the OECD agree. In 2016, we have every 5 years, we have a big ministerial meeting. So all your ministers are coming to Paris, the OECD, and the health ministers agreed on this analysis, and they decided that we need to move to a next generation of health reforms. Many of our health systems are designed in the 20th century. They are largely clinically focused, strong curative focus. And this next generation of health systems are health systems that are built around the needs of patients, around the needs of people. This means that the perspective of the patient, the outcomes as reported by patients and the experiences become a leading principle and become just as important as all the other clinical parameters. Now, we are here today with primary care people, and this might sound familiar. We all know that in primary care, looking at the whole person and taking that as a starting point, it has always been a traditional cornerstone of family practice or primary care, but it's not necessarily always the case on a broader system level. Now, there's another reason that make measuring people's outcomes and experiences urgent. Most countries in the OECD have aging populations and an ever-rising number of people who live with 1, 2, or even more chronic conditions. About the age of 65, a majority, almost 2/3 of the people live with at least 1, but often more chronic conditions. Even 4 or 5 is not an exception. This group of people with chronic conditions is the largest and most rapidly growing group of healthcare users. And particularly for the healthcare providers here today, I'm telling you nothing new. People with chronic conditions form also a very heterogeneous group. Some of them need help to get out of bed, whereas others run marathons. But what they have in common is that they need longitudinal care, regular checkups, medication, often diets, etc., over a longer period of time. They need support to go on with their lives. Now, if we want to make this transition towards people-centered health systems, it starts with the right data. First of all, it's a no-brainer. It's difficult to improve what you do not measure. Second, if we take people's outcomes and experience seriously, and we talk a lot about this these days at conferences, so why would we not measure everything systematically? Or why would we measure everything systematically except that? So when measuring people reported outcomes and experiences, we talk about so-called prompts and prems. Now, here is, I'm going to show you a little bit more, to make this a bit more specific. Prompts and prems, patient-reported outcomes. This is a part of our framework, and we can look at different elements. For instance, symptoms, pain, fatigue, shortness of breath, functioning, physical, mental, social, but also a more generic prompts like self-reported health and health-related quality of life. When looking at just an example of 2 prompts that we have, These are coming from promise. We don't have an ambition to reinvent the wheel here. So we have done a thorough analysis of existing promise tools. And here are just a few examples where we ask, for instance, in the past 7 days, how would you rate your fatigue on average? The past 7 days, how much does pain interfere with your daily activities? Very well validated instruments and often used. Here are a few examples of PREMs, just to give you an idea. These are the experiences with care, and here we ask, for instance, to what extent do you receive useful information at the time that you need it, or are your family, friends, and or carers involved as much as you want it in your care process? Now, we are doing this with an international network of patient organizations, providers, policymakers, and academics. And the slide that you've already got a sneak preview here, you can see the countries that are currently joined the Paris Initiative. So these countries have on a ministerial level committed to this project and also financially committed. And we're currently busy with implementing this survey in all these countries. Now, what is special about this initiative is that first, it is built with the continuous involvement of all these stakeholders. So that's what I meant with a shared effort. It's not something that we invent in Paris and we try to impose to you. It's important that healthcare providers, patient organizations are involved in this process. Second, what is different is that we are creating a so-called multi-level data set. So it's not a population-based survey. We are sampling providers and patients in providers. So it will be possible to look at variation on different levels, also within country. And third is that, as you can see, 21 countries have already committed to this survey. Maybe good to notice that there are also a few non-members. So we have Saudi Arabia and Romania. As you can see here, they are not OECD members, but it very often happens that international initiatives are done together with non-members or partners. Now, this valuable data set will make patient voice heard in the assessment of health systems. It will help providers better understand patients' needs, and it will also foster a dialogue among peers. So it will help policymakers identifying what requires policy attention. And you might have heard about our PISA initiative, which is something completely different. It's in the domain of education. And here, these days, we're sometimes talking about the PISA shock, where countries suddenly discovered that they are performing on certain indicators much worse than others. This is often a sort of wake-up call for policymakers, or maybe something is going exceptionally well, and that is an opportunity to help people, other countries, to learn from that. Now, my call for action today goes beyond this survey. If we say that we care about patients, if we say that healthcare should be oriented towards their needs, we should take patients' expertise seriously. And I call it expertise because they are experts about their own lives, and they are the only ones who can tell you how they experience the outcomes of care. People who are still looking at this from a 20th century perspective call this sometimes soft data. As if on the one hand, we have the serious clinical data that is essential, and on the other hand, we have something like satisfaction, which is nice to know. But if we take this seriously, we should realize that we are not talking about soft data here. We are talking about a serious gap in our knowledge. It's still a black box, and this black box contains crucial information about the essence of healthcare. Now, there are scientifically robust instruments. They are out there. All the legislations, as well technical solutions are there. The question now is, are we scaring away because of the potential challenges, because we never said it's going to be easy? Or are we willing to take the patient's voice seriously and give this perspective a serious place in the way we look at healthcare? Now, I would like to leave you with a couple of take-home messages. Patient-reported data are essential, an essential source to assess the results of healthcare, and should be taken just as seriously as financial data, prescription data, mortality data. Now, we're all pro-patients, but it's time to walk the talk. Paris is coming to your countries, and we need your support to make this happen. We cannot do this on our own. We have national project managers in your countries, but this initiative needs to be supported by the people on the ground, by the patients, by the healthcare providers. And finally, the very essence of healthcare is helping people living better lives. Back to you, Mr. Chair.